projects, community-led, community-based projects. We're gonna order anyway, no? So we're gonna start with Stella, Stella Zine from the US. No, I'm just gonna read your bio really quick. Yeah. So Stella, it's non-conforming gender femme, neurodivergent. It's part of the Liberatory Harm Reduction and National Survivors Unions, Southern Liaison. She has held numerous roles at various US organizations, providing frontline harm reduction, street outreach services for Georgia Harm Reduction Coalition to co-design community-led research programs and feminist data analysis for Emory Snell Hudson Woodford School of Nursing. Her presentation is called Empowering Voices, Research Through Liberatory Harm Reduction and Healing Justice Frameworks. So Maite is here, so we have the whole panel. So, sorry, just to check it out, it's like 10, 12, 15 minutes. I'll be just pushing a little bit there, and no worries.
Been planning for that, editing down. Okay, thank you so much, and it's exciting to be here. I need to get the slide up. Is that it? Is it doing it? Okay. This presentation is called Empowering Voices, Research Through Liberatory Harm Reduction and Healing Justice Frameworks, presented by myself, Stella Zine. This work, in part, has been funded by the Injury Prevention Research Center at Emory University, IPRICE, and right now is under threat because of, we know why, the authoritarian craziness going on in the US. Okay, second slide. Did it. Okay. To introduce myself a little further, my name is Stella Zine, and based in Atlanta, Athens. I'm a researcher with lived expertise, living experience. In my case, of polysubstance use, drug use, overdose, housing insecurity, homelessness, surviving state violence, and intimate partner violence. Have been a member of a U.S. National Drug User Union, National Survivors Union for 5 years. I work especially in the areas of sex work, trafficking, and Hep C and HCV. Same thing. Okay, WRLE. I was thinking like the YMCA. I was thinking W. Okay. RWLE or RWLLE, researcher with lived and living experience, is a phrase and a role reflecting meaningful engagement for people who use drugs with time and care and capacity building. Having researchers with lived experience or living experience can be less extractive and more meaningful, in a more meaningful way to include people who use drugs into research. And let's see, where are we at? I want to uplift the study. For that term, researcher with lived experience, there was an awesome study, and basically it highlights how the research process itself can demonstrate a commitment to addressing inequities. Like the process itself. Of course, it's kind of common knowledge that involving us, we get better data. There's better data when people that use drugs are a part of, the research. But what there hasn't been as much work on is that the process itself is important too. The needs of people who use drugs. And basically, and so the study is, it's up there. I'll move along. Okay, I have 2 pictures up there. One is before I say that, I want to do Nothing About Us Without Us. And I've got it in Spanish, too, thanks to my wonderful interpreter on our team, Daniel. Nothing about us without us, and in research at every level of research. And just putting it out there, think about it, chew on it. Living expertise exists on a spectrum. Just want to say that, just put that out there. Caveat 2, for those of us with lived experience, that structural awareness matters. And what I mean by that is people coming out of recovery in like prisons, sometimes they'll have these messages that are encouraging these horrible laws, like, oh, it's so good I got arrested. Oh, it's so good they took my kids away. But we have to do that work to learn structural issues, and so we're not, so the people who lived experience are, I said it 3 times, so moving on. 2 pictures of me, and just to introduce myself. One is recently at the steps of the Atlanta City Hall advocating for sex workers. The second one is me 30 years ago singing in a punk queercore band at a time when I was slinging condoms and syringes in the streets of Atlanta for AHARC, Atlanta Harm Reduction, Georgia Harm Reduction Coalition. I share this here because it conveys the beginning of my own embracing of liberatory harm reduction. Yeah. And so with liberatory harm reduction, different than public health, that makes sense. And so I want to quote, there's so much to say, and I'm working on 10, 12 minutes, but healing justice, I'm going to quote from some of the architects. And a lot of the architects are from Atlanta, the South, the American South. One of the quotes from Kindred Collective. Healing justice is a political strategy conceived in 2005 and formally launched in 2006 by the Kindred Southern Healing Justice Collective to intervene and respond to generational trauma and systemic oppression and build community survivor-led responses rooted in Southern traditions of resilience to sustain our emotional, physical, spiritual, psychic, and environmental well-being. And then just the other slide on, I didn't switch the slide. Oh, there we go, okay. And then that slide, there's a little picture where it has healing justice, and there are pillars upholding that, and harm reduction is one of them. I'm not gonna read all of them right now. I recommend getting the book, Healing Justice Lineages by Kara Page, one of the original architects of the healing justice framework. But harm reduction, like abolition harm reduction, liberatory harm reduction being one of the pillars, and repro justice and environmental justice. And look, it's in Spanish too up there, okay? Okay, components of the healing justice framework. I'm gonna move it along, and I'm only gonna do like 2 here. It's a framework created by Black queer women. Now that needs to be said, and I need to show the receipts because I'm a white person, okay? And this is not to be co-opted, that's centered, that people of BIPOC, and in this case, Black queer women, and original architect, Kara Page, Erica Woodward, and to my white folks out there, I want to shout out Susan Rowlow. She wrote the book that is included in a lot of the healing justice books and was invited to write. Her book is poetry, and it's, kind of doing that processing work of being a white person on this land that, 2 big wounds of genocide and slavery, So, yeah. And Susan Rowlow's book is brilliant. She was at that conference, too. Okay, and then challenging ideologies of eugenic ideologies within the medical industrial complex. Okay, the next one. Liberatory harm reduction, because that's also in the abstract. And liberatory harm reduction is, let me see, do I have the right slide? Oh yeah, I'm going back to my notes here for a second. Okay, liberatory harm reduction. Some components of this framework: peer-to-peer, anti-carceral, trans justice, disability justice. And when I showed that picture of me in a punk band, and punk movements, like in the book on saving our own lives, liberatory practice of harm reduction, big shout out to punk rockers and harm reduction, okay? I'm just saying, this is a really important, there's a chapter on it, the history, the lineage, and liberatory harm reduction highlights, documents, honors, and uplifts that of our contributions, It is written so brilliantly in Shira Hassan's book, Saving Our Own Lives. Okay, some examples. Anarcho-peace punks, countless harm reduction benefits in the punk scenes. Queer punk, and Chloe Dzibolo, and Trans Sisters. I was so excited to see that in that book, because from the 90s, Chloe was a trans woman who died, and a punk rocker, and I didn't know how much she did with harm reduction, was starting syringe exchanges in New York for trans women. In Atlanta, okay, Mona Bennett. I've just got to shout out to Mona Bennett, who's here. Mother of Atlanta harm reduction and a liberatory harm reduction leader, okay? Benjamin Opalfox. I just want to shout him out. In all of our scenes, we know our people, and then there's different scenes. Okay, this is why I added the early picture of myself, introducing myself, having an awakening of liberatory harm reduction, and about how a lot of times we get pathologized by the things that are healing us, by the looks, the things that we're doing, and so relating and identifying is so important, in our communities, and different communities relate and identify with different things, but relating in, and also for dissolving destructive power imbalances in research. And in our study, our PI, because I'm getting to that, in our PI, Sarah, one of our PIs, Sarah Fabrice Cordero, who's also here, this amazing punk rocker, can I say punk? She's got the best tattoos around. Okay, 5 minutes, so thank you. Honors and uplifts punk, drug, creative, and queer alternative cultures and embodies many of these herself, which is something incredibly disarming and so helpful to working with people who use drugs. And also the sixth slide, let's see, where am I at? Okay, abstract, wrote an abstract. I'm really proud of that, y'all. Okay. This has to do with, I'll get to that, but it's on the program online, so I'm not gonna read all that. It's up there, and I just wanted to show it there. And to go to the next one, okay, researchers that included myself came together for a study for this presentation. I'm highlighting my involvement from January to October. The goal of the study was to identify barriers and facilitators to implementing a community drug checking app. And at the Department of Health for Diverse Communities, for people who use drugs in Fulton County. Picture, this one was at an anti-corporate LGBT event called Southern Fried Queer Pride, and I decided to wear the shirt just to honor it, a Southern anti-corporate event. And our team members and our research team members I worked with is Sarah, who I'd mentioned, Fawaz Shannon, who should be here, and because he's on a student visa and because all the chaos happening could not come, was scared to fly, and that shouldn't be. Hayden Henderson, who's in that picture, and from an ASO, an AIDS service organization in Atlanta. Athena Sherman, Sarah's beloved mentor and professor at Emory. And Daniel Smith, who's here and has made our trip, could speak fluent Spanish, and is a senior data analysis, by the way. And, okay, so, zines, okay. So identifying and implementing novel strategies to engage people who use drugs and harm reduction and drug checking is essential for preventing overdose and from contaminated drugs, overdose from contaminated drugs. By refining our CER, our community engaged practices, significantly informed by the valuable contribute from us, people who use drugs, we will continue to advance effectiveness in our research and intervention strategies in Atlanta. And so with that one, let me pull that one up. That one is, what page? That's page 8, okay. Okay, methods I brought to our research team, informed by previous survey and data collected for Georgia Harm Reduction Coalition, for Hep C, and the Beyond Tested Cure team. For that work, I handed out tons of zines, harm reduction zines, when giving surveys, and suggested we do that or make our own for this drug checking study, which was implemented, and we handed out many at the Southern Fried Queer Pride, and from what I understand, strategies like this was implemented in other survey sites. Also highlighting that zines are integral to liberatory harm reduction and came especially out of the punk movement, just by the way. And also I stood up to include which got implemented and well received on xylazine, nitazine, sex work, drug checking for HRT, silicone on the surveys, which was covered. And so in the next slide, very close to the last one, y'all. Okay, community-driven research, gotta mention it. Utilizing many DPA and National Survivor Union community-driven research recommendations has been very helpful. And so with that, I'm going to pull up this slide. I was at it, wasn't I? Yes, and I have some Spanish in there. For community-driven, or at least co-driven research is really helpful and really important for studies with marginalized populations which mistrust researchers. Who mistrusts researchers? I'm just saying. And I've walked through a lot, and I'm in it because it's an important place to be. They need us, we need them, and I'm here for it. So I want to uplift National Survivors Union, which I'm a member of, and 2 studies, and the work of Katie Simon, Sarah Brothers, Abby, Nick Voles, and Louise Vincent, and other names up there, and also community-driven. This is 2025. This is peer-reviewed work. It's in community-driven research with people who use drugs, a virtual project during multiple epidemics. 2025. And then there's another one for 2021 that's really important. And then one of the big things to implement, time and care for capacity building. Time, care, it's big, we know. And for me, let's see, I know it was 1 minute, so I'm going to go to the next slide. And for me, this is the survey, that maybe that should have been first, but I had to build about healing justice, we need that. Creating the survey and develop first one survey and then 2 side surveys, one that if people were using HRT or silicone outside of prescription, just that drug checking for that too, y'all, especially in the states where it's so criminalized. And also, for people that are checking their drugs already, a more in-depth. And then I was a part of developing questions. Like one of the things we implemented from CDR was that we are a part of creating the questions and even the development of the questions. And it really happened. There were elements that is really fabulous. And it's in the South, qualitative interview. I learned the word CFR. To any researcher, people that know about that. Co-developed an interview guide with semi-structured interviews. I worked especially with Sarah on this, and she's just wonderful. And then Hayden Henderson from A Positive Impact in Atlanta. Capacity building for me included Microsoft, because I do on Google, because it's accessible, y'all. Google, but anyway, and that's what we use at NSU. We use Google stuff, but I used Microsoft because universities use that. It takes capacity building. CT training. I'm fucking CT trained, that happened. And I'm just saying that, and I know from NSU, and we're working on getting people CT trained, being IRB approved, and also I was supported in educational career development. And so that is 10 slides, y'all. And I'm really excited about being on this panel with a lot of people who lived in living experience. This is really exciting. And so, thank you. And next.
Yeah, beautiful, Stella. Thank you. Now, first of all, we have a full room. That's really nice. I want to say, if you guys want to see, you can maybe sit the other side so you can see the presentations. Go ahead, no worries. No, it's okay. We're in Latin America, so you can move around. We already started late, so no worries. Thanks everyone for being here. So I just want to wrap up some of the things that Stella said that I found it really, really interesting. As a drug user myself, we've done some community-led research and people lived experience, and we hired drug users, so definitely I do think that's the way to go. We do find kind of worry when academics just come up and tell you pass this survey and okay, we're going to get from that, no? So the political approach and intersectionality, everything, I think that's the spirit of harm reduction itself, no? It goes much beyond sanitary or health-based approach. So now we have Dorah Nalukenge. I pronounced it correct? Yeah, let's say. Beautiful. So Dorah is from Uganda. She's a research assistant with the Makerere University School of Public Health, working in the field of HIV, PrEP, harm reduction. She has spirit in data collection, analysis, and reporting. Dorah is passionate about contributing to evidence-based interventions that improve health outcomes in vulnerable populations. The name of her presentation is Community-Led HIV Self-Testing Among Men Who Use Oral Substances and Other Illicit Drugs in Kampala, Uganda. Implicational experiences and plan for a scale up. So you have 15 minutes or a little bit.
Hello. Good morning. Okay, my name is Dorah, and I come from Uganda, Kampala. I am from Makerere University School of Public Health, so I'm here to present my abstract. So, community-led HIV self-testing amongst men who use oral substances and other illicit drugs in Kampala, Uganda, implementation experiences, and plans for a scale-up. So let's go to the background. So, men who use oral substances and other illicit drugs are disproportionately affected by HIV due to elevated risk behaviors. So community-led HIV self-testing has emerged as a promising strategy to enhance testing uptake among hard-to-reach populations. However, this approach is yet to be scaled up to reach more populations. So we examined HIV self-testing implementation experiences in Kampala and neighboring communities outside the urban city in Uganda to inform future programming and scale up. So let's go to the methods. So this was a mixed method. This was a mixed method study that involved qualitative and quantitative approaches with 224 participants, respectively. So participants were recruited from specific locations where men who use drugs and other illicit drugs were known to congregate, like the bars, in places where they normally be. So this was a social network-based peer-to-peer intervention in which we identified and trained laymen as peer leaders. So they were trained and given oral fluid HIV self-test kits to distribute to members in their social networks. Statistical data analysis was done for quantitative components and thematic analysis for qualitative components. So there was a high HIV self-testing uptake. So, and this indicates that the significant majority of the target population, they accepted and utilized the HIV test kits, meaning they used them. There was a substantial testing yield that was found 12% were HIV positive. And this finding indicates that there was a notable portion of those tested that were HIV positive, and they were later being linked to care. That was 90%. So meaning there was a success of the program where we were able to connect most people who were tested positive to care and treatment in healthcare centers within a short period of time. So peer leaders played a vital role in encouraging people within their social networks to take the HIV self-test kits to test at home. So, however, there were some men who reported that they needed additional support before or during or after HIV self-testing, and some needed pre-testing counseling. Oh. The implementation experiences. So almost all the peer leaders successfully distributed the kits to their social network members and trained them on how to use these kits to self-test on themselves. So most of the users used the kits correctly to self-test for HIV, except some few men who made a few mistakes in there. So 2/3 of the men, that is 66%, easily picked the kits from their peer leaders on their first day and the next day. However,
The remaining 34% required an extra effort to reach them, like they were not around, others missed, so they had to look for them. Some HIV positive men lied to the study team that they were HIV negative, but as per the guidelines of the manufacturer guidelines of this oral self-testing kit, positive men should not have to use these HIV self-test kits. So if you got the implications, it is possible to use a layman in the community who can help in distributing HIV self-test kits to his peers. You can train them on how to use them so they can train others and distribute to their fellow people. So there may be need of a supervised peer-led HIV self-testing in some instances, like for men who use drugs and those who find it difficult in performing these tests on themselves and interpreting the results correctly. So engaging stakeholders, foster partnership with local leaders, health workers, Ministry of Health, and organizations to facilitate awareness campaigns on drug abuse prevention programs and HIV self-testing programs among people who use. So in conclusion, our study confirms that the community-led HIV self-testing model So our study confirms that the community-led HIV self-testing model can successfully improve HIV self-testing uptake and linkage to care among men who use oral substances and drugs in the community. However, challenges in this use of kits and interpretation results are still abound, suggesting a need for additional sensitization of potential users before the model is scaled up to other communities. Thank you.
Beautiful, Dorah. Thank you very much. You gave us a lot of time now for questions after. No? And I wanted to also say something about it. I find it really, really interesting. I think definitely peer-led or community-based processes show that there's more availability or possibilities to engage with treatment or attention. So definitely one of the things we always say in any harm reduction program, it should be peer-based or community-led. So now we have Matt Southwell. I know Matt for a long time. I could say he's one of my mentors. Learn a lot from this guy, and I'm sure many people here will have learned a lot from Matt. So thank you. I think it's important to do that. So I'll just give a quick one. Matt is founder of a pioneering community-led harm reduction services in East London to response of HIV during the 1990s. He has championed peer-led needle syringe exchange programs with technical support while remaining a volunteer peer-to-peer needle syringe program in his local community. His speech, I have it in Spanish here, so it's on point. The story of how people who inject drugs develop needle syringe programs and what this tells us about participatory planning, innovation, and funding of needle syringe programs, given the global aspirations to let communities lead.
Thank you very much, Ernesto, for that kind introduction. Sorry, guys, I was very precise on the opening title and then got carried away on the subtitle. Okay, so I'm going to talk to you about peer-to-peer needle and syringe program. I'm going to talk to you about the history of needle and syringe program, but through a community-led lens. I'm very happy to be part of this big UNITAID study with multiple consortiums. I'm particularly part of the Frontline AIDS Consortium, working with COACT, my other community-led technical support agency I work for. Huge array of exciting partners. Input, another key partner in the process. This is the first time we've had UNITAID, the part of the UN that deals with innovation, focusing on harm reduction, and making the focus community-led, which is amazing. So UNITAID is making that focus on community-led because there's a growing recognition around the world that communities work, and that the community-led is the most effective, efficient model for delivering harm reduction. Of course, there are challenges and issues that go with delivering through a criminalized community, but in many ways, that's why it's also so successful. The global community and the global AIDS strategy has set bold targets for meaningful participation in the global HIV response, and particularly around HIV prevention. And in our world, that means peer-to-peer needle and syringe program, among other peer interventions. If you want to know more about some of the case studies that I'm going to be talking about, including the peer-to-peer needle and syringe program that I run in my local community in Bath in the west of England, you can find them in this technical guide or technical briefing written by the European Network of People Who Use Drugs, which you can find on their website along with other key peer-to-peer resources. So let's go back and look at the history of NSP. And look, even in the writing of this and the sharing of some of my ideas on Facebook, I had a lot of community members coming in and going, no, that's not right. This is more the correct thing. And I really appreciate that feedback to get our early history right. If I've missed out bits of the history, and clearly I'm not going to cover everything happening everywhere else in the world, please see this speech as an invitation to contribute. It's not the end of the story, it's the beginning of trying to tell the story. So for us, many of us in Europe look to the Netherlands as one of the key founding moments of peer-to-peer NSP. Nico Adrian led an outreach-based NSP responding to hepatitis B, in fact, in 1981 in Rotterdam. And quite soon after, the Amsterdam city authorities then supported MDHG, which is a hybrid drug user organization, to run the world's first fixed site, one of the first fixed site NSPs. So a key moment. Clearly, the Dutch model started with very much a peer-led model, has moved away from that over time, which I think is part of the history of NSP, which I'll come back to. Then turning to Liverpool, I think we know Liverpool very much as a sort of service delivery-based response, which is very much the way the UK responded. We have Jerry Stimson there in the middle, who did this study with 10 local areas in the UK, set the history for NSP. But what Alan Matthews and some of the other peers involved in that scene remind me was that actually Alan Parry, who was the tallest member of the top photograph, was running an illegal peer NSP or a peer-to-peer NSP before the official program started, supported by Alan Matthews, who was working for a medical manufacturing company, who was giving him needles and syringes to give out to the community. And these peer-to-peer origin stories are often what then goes on to inform formal programs beyond that time. And I think it's interesting in the UK that we haven't always sustained that peer-to-peer part into the ongoing mainstream program. However, one big exception to that, and I'm very proud that it's the agency that I founded back in 1980. Well, it was formed in 1991, but the work started around 1998. The Healthy Options team was a team that ran in East London, part of the National Health Service. So really showing how that once you open up work to people who use drugs, it doesn't mean that we're the only workers in teams, but it means we bring nuance and sensitivity to those teams, working alongside doctors, nurses, the wonderful Chris Ford, there shown in the bottom left, one of our key general practitioner allies who really brought the general practitioners alongside the drug user initiatives to help us be effective. So it's not either or, sometimes it's about both. But when you're making decisions with people who use drugs in the room, you start to think in a very different way about what goes on. Try to think about taking someone's script away when there's people on scripts in the room reminding you of what the consequences of that are. And some wonderful figures, Nikki Bath, Teresa Jankowska, another leader not there, Jay Foster, another leader not there, the wonderful George and Abdi, who are two of our key community advocates. And me without a beard back in the day. So then, if you think about a model that's fully integrated, like the London model, like the East London model, imagine that at a whole system level, which is where we get when we start to look at New Zealand and Australia. So New Zealand in Wellington has the first state-funded needle and syringe program, is led by a drug user organisation or at least a peer-to-peer needle and syringe program called DIVO, and that sorry, the wrong one. That set the scene for the other 20 peer-to-peer NSPs that came into New Zealand, and those were coordinated by Charles Henderson and I forgot his name, George, who are both coordinating and running this program. Interestingly, they don't openly identify as drug user organisations in the same way, but they're very clearly peer-to-peer needle and syringe programs. If we turn to Australia, really the powerhouse of injecting drug users movement, a country that really managed to stop HIV in its tracks and has gone on to be one of the real experts of hepatitis C responses. And definitely as we do the UNITAID project, we're learning a lot from the Australian experience. And I think what Australia shows is not the drug users running the whole scene, but when you have a backbone of drug user organisations running needle and syringe programs, it sets a quality standard. It sets a low threshold to services, and it means you have this wonderful peer education coming out of the drug using community, which impacts not just on the drug user run organisations, but on the wider system. And I think if we could look now at how researchers work in an integrated way, the number of drug users going back to do qualifications supported by the wider system, that's the Healthy Options team at system level. And it's notable the Healthy Options team was hard closed in 2001 by my revengeful medical director who hated the fact I'd transformed his stigmatizing services. So now let's look to the US. This is the bit I'm looking to see if I get right. Please apologise in advance if I don't. So look, I think there's, again, like all these origin stories, there's multiple origin stories because people who use drugs were responding to a common set of issues that they were seeing in their communities. So I think the key message is not who got there first, it's the fact there were a number of firsts happening at different points, and they also interacted and informed each other. So there's a much more sort of strongly activist-orientated model from John Struan-Jones, who was running the National AIDS Brigade. But I think really the most impactful of the needle and syringe programs at that time was the NASN, run by the wonderful Dave Burrows. Dave Burgess, sorry, my brain is going. Dave Burrows is someone completely different. The wonderful Dave Burgess, a real hero of the US movement. And I think what Dave did was, for many drug user organisations, provided a place where people could organise under the NASN umbrella and not have to come out publicly as drug user organisations against a very hostile background. Similar story to what was happening in New Zealand in some ways. Mark Kinsley then plays an absolutely critical role as one of the people doing some of this really early formulative work of tracking coded needles and syringes in and out of New York, really proving for the rest of us, giving us that clear evidence that needle and syringe programs works. And I think that's absolutely critical. So I'm just keeping an eye on my time. Yeah, that's absolutely critical to proving the evidence, and we'll come back to that later on. Then the Urban Survivors Union, a key attempt by US drug users to self-organise, reflecting the improving policy environment that allows people to start openly talking as drug user groups, acknowledging some really great friends in the room, Shiloh, Tim, and, my brain names, and Louise and Riley. Sorry, my brain is going dead. Altitude sickness kicking in. And then I think the other thing is to acknowledge that across the US, you also have these wonderful state-based drug user organisations doing their things, and particularly to pick up on Jess Chilly's wonderful network in New England. And also understanding that what drug user groups do is not just give out needles and syringes, but they're doing that much bigger advocacy, fighting for change, which I think you don't get from a much more service delivery style model. So why do we think peer-to-peer NSP is so important? Well, it has this function of privileged access. We saw in the Healthy Options team working in a very diverse area of East London. No, it allowed us to reach out into the Italian drug-using community that had 50% HIV rates, really critical for us to reach and support that community. But also, as drug use impacted on different migrant communities, the ability to work with those communities to develop responses. Picking out here Yasser Ali Khan from Pakistan with HIV Buddies, amazing work on chemsex, incredible bravery in a hugely conservative society to be working through dating apps to give out needles and syringes to our community. Diane Edom from Nigeria, from Lagos, highlighting the power of reaching out to women and mothers who inject drugs, often really struggling to engage in services given the fear of having our kids taken away, and understanding, again, this privileged access, being able to reach out through our community networks. And then going back to Mark's point, why is research so important? Because we sit on these global guidelines. If you don't have the evidence, you can't prove the case, you can't write the guidelines. The WHO always work with communities as part of their mandate, and it gives us huge opportunities, and it's one of the things our global network input does for us all. The UNITAID study, absolutely critical, apart from Annie Madden from Australia, now working for Input, coming back with her own PhD, so now being a key research leader as well as a key drug user leader, using this model of values and preferences, and then having Judy and now Anton chairing the Community Advisory Board for this UNITAID study, really showing how things work. And we're all super excited that the WHO is now rewriting its technical intervention tool on how to run needle and syringe programs. First time it's been rewritten for 20 years. And so really a key opportunity to start highlighting community models, low dead space needles and syringes, the whole wide array of interventions that, that needle and syringe programs facilitate. Critically important to notice, of the 10 people on the working group, 5 are people who inject drugs with experience of running NSPs. And so big up to the WHO for that. Going on there. And so why is it so important to have those guidelines? Well, let me just cite Nigeria. We talk about this issue of how do we get more peer-to-peer NSP happening. Because we have global guidelines saying that drug users should be involved, what it means is that then when governments turn around to those of us who provide technical advice like COACT, and we say, well, the global guidelines say this should be community-led, then the Nigerian government, with support from the Global Fund, the WHO, UNODC, and others, says, right, how do we do that? And then we have these wonderful community-led organisations as part of the 2019 pilot, start to implement needle and syringe program. First time drug users were ever asked in the world, what needles and syringes would you actually like to have? That then gets formalized in the values and preferences study that UNITAID is now doing, and Nigeria is the only country with 2 sites in 2 consortiums operating, the wonderful YABS in Oyo State and the wonderful DAPO in Gombe State, 2 remarkable and highlighting that, why is Nigeria so strong? Well, one, because of amazing leaders like Animi George and Anidi Akpan, but also because Input has been doing long-term technical support with Duran, their national network. So this is about a national response, but also one backed up and supported by international partners. So, if people say to you that drug user organisations can't run peer-to-peer, let me just cite 4 examples that just tell you that that is utter bollocks. So firstly, let me highlight the Georgian network of people who use drugs. in one of the most heavily criminalized countries in the world, where you could be stopped in the street and sent to a police station to be drug tested, and then you would be prosecuted for every drug found in your bloodstream. Against that backdrop, the Georgian Network of People Who Use Drugs had a whole series of state groups giving out needles and syringes. We have in Myanmar, in the middle of a conflict zone, this is Ko and his team at Pure Balanced Mind, part of the Kachin drug user network, 13 drug user groups working in the middle of a war situation. Pure Balanced Mind have an MOU with the Kachin Independence Army that allows them to deliver needles and syringes across conflict zones because they used to go to school with some of the people in the KIA, so they have their own MOU that allows them to work. I mean, you just cannot imagine a service delivery model achieving that. You heard Judy Chang acknowledge Abdur Rahim Rajay and the team at Bridge Hope Health Organisation in Afghanistan. Just remarkable work. I mean, really remarkable to continue working through the changes in the government and continuing to deliver harm reduction, becoming the Afghanistan drug user organisation under the Taliban and managing to continue working in those conditions. Remarkable. And then another remarkable organisation, we've seen this hideous drug war against people who use drugs in the Philippines. 25,000 of our members summarily executed through death squads on the street. And in the midst of that, I Do Care is a peer-led drug user organisation running in Cebu City who kept their community alive through this murderous outbreak and delivered peer-to-peer NSP. Another remarkable organisation. Joachim and his team deserve a round of applause as well. And so the future, this is my last slide, just to say, what is the future? The future is peer-led drug consumption rooms. Now, as what we've been saying at the INSU conference and again and again and again, is that we don't want highly medicalised surgical style drug consumption rooms. That's not where we choose to use drugs. No, I think we've said this again and again and again, and we keep getting told, oh yeah, to prove the case, we need to have this very expensive model like we've seen in Athens, in Glasgow. I get it on one level, but it just means you end up with very centralized DCRs that are very expensive and difficult to duplicate. In Lisbon, GAT runs an amazing peer-to-peer two-booth drug consumption room, showing that dispersed, local, community-led is far more effective. And to finish, let's go to our friends in Canada. Matt Bond, highlighted here as a symbol of our Canadian brothers and sisters facing brutal pushback against harm reduction right now, seeing devastating loss of leaders. And I think what we should recognize is often, like we saw in the HIV epidemic, that's when innovation occurs in these crises. So don't see things like safe supply, peer-led drug consumption rooms as an anathema to harm reduction. This is the future of harm reduction. Harm reduction does best in a crisis situation. So just to finish by saying the future is peer-to-peer. The question is, why do we not always sustain peer-to-peer when it's so often the origins of NSP? And I think we need to do better with DCR. Thank you very much.
Thank you, Matt. Great presentation, great work. No, I definitely think we're carrying this history, this memory from those who have led the way, and to have this many people here and have a conference in Colombia now. It's definitely, I don't know, I really enjoy it. At the end, we are the ones that have to own, have to know and knowledge this community, and seeing that it goes much beyond just giving out syringes. It's about advocacy, it's about fighting for change. Nothing about us without us. So thank you very much, Matt. So now we have Jeremy Kalicum from Dolph. I think we don't have to present Jeremy, also because we have some problems with the bio, So at the end, I just ended with Jeremy from the Drug Users Liberation Front.
Yeah, thank you so much. It's great to be here, and I'm very impressed by what all my other panelists who had to say. I think the Drug User Liberation Front has had a big impact and made waves in the international community, and DOLF means a lot of different things to a lot of different people. And in the spirit of the panel, and what all my other panelists had to say is that the responses to different contexts and different scenarios are very, very different, and it can look very, very different. And the fact is that what DOLF did, which I'll go and I'll explain, but what we did, was just it was a community local response to our friends dying, our community dying, and what community does and why it's so powerful is because we do what we need to do, because it's our community, because nobody else is seeing what's happening and the severity of what's happening, because people live their own lives and people do their own things, and different communities have they're separate, and if not the community, then who's going to come? And nobody does come, and that's why we need to do it ourselves. So that's why DOLF did what it did, because nobody was coming. Our initiative happened 5 years into a declared public health emergency of thousands of people dying every year in a very, very visible way in the heart of one of the biggest cities in Canada, and nobody did anything, and nobody's doing anything. And if our court case doesn't go through, maybe nobody will do anything, and it'll just be left to community who's constantly being decimated, persistent death. So it's bleak, right? The situation's bleak, and community comes together, and they support each other, and we just try to get through in the best way we can. And saying this all, just also acknowledging that I come from a place of pretty immense privilege, in this community. I'm not a person who's experienced a lot of harms from drug use. I have an education and capacity to do what DOLF was, and the way that we did. You can go to the next slide if you want. Oh, I do my own slides. Sorry, but the way that we did DOLF was, and the reason we were able to do it was a matter of circumstance. Eris, myself, the volunteers at DOLF, we aren't special or spectacular. We're just people trying to do the best with what we had, and what we had was community. We worked from a place of like my co-presenter said, we're working from a place of very rich history and standing on the shoulders of giants of people who've done this work before us to build the platform on which DOLF could jump off and do this incredible initiative. But it was in this context that was different from our predecessors. So the overdose crisis is relatively, it's 9 years now, but it's been pretty new. And when people like Vandu were first starting up, and all the harm reduction responses that we have in Vancouver are really a response to the HIV/AIDS crisis, right? And needle exchanges, even Crosstown, which is our medicalized heroin program, that was a response to back then, all the stuff we have is a response to that. And I realize that the overdose crisis isn't a completely global issue, but that was our issue. So that's what we were trying to respond to, and it's so clear of what the solution is, because the people in community and the people we've consulted with and Eris and I were organizing drug user groups in the downtown east side in British Columbia, and we're engaging with the national drug user groups. It's like very, very clear. They're like, that we need regulation. Like, we need drugs where we know what's in there. But, and that was crystal clear. And that came from engaging with people, not just people who use drugs, but also people who distribute drugs, which, this is a very enlightening conversation I had last night, of, this really critical point that people who distribute drugs are, like, largely kind of not in the conversation, right? And I think that's like a conversation that needs to happen, and is very, very important, particularly in the context of overdose and the need for regulation to stop people from dying and overdosing, is that if there's nothing that's going to stop, I'm not even keeping track of my time, there's nothing that's going to stop this crisis or prevent this crisis from happening other than finding a way to regulate the supply. And you can't do that on, like, kind of bottom, just like substance user base. You need to go distributor levels, because you need to exponentiate the effect of the programs you're having, and that can absolutely be peer-to-peer, but like, it needs to go up. Like, we can't just keep focusing on, in the context of the overdose crisis and the dire need for regulation, on just kind of like street level, the user-based sort of interventions, because we'll never get there. There's not enough needle exchange, not enough overdose prevention sites in the world. We could have an overdose prevention site on every single corner, and people would still be using alone, because that's just, anyone who uses drugs is like, I'm gonna use alone, right? And it's like the reality, and we can put out the messaging like, don't use alone. Of course, like, you shouldn't use alone, but like, I'm gonna. And it's just the reality, like, no, I keep forgetting. Okay, so that's where we got to Dolph from. It was from standing on the shoulders of giants and all this work before us, and the need to respond to this really, really dire situation, and just being in a place of privilege, having the skills and access to technologies, and the ability to access different levels in the bureaucracy to get support. Because one thing people don't really know about Dolph is that we did have fucking permission to operate. Like, we tried to go through all the different levels to make sure we could do this as legitimately as possible. We had permission from the federal government to do exponentiated drug checking, which is what is Dolph, just to be clear, right? So that's what we were, was like a community-based service where we tried to integrate research, and I think you spoke really, really well on the extractivist nature of research and the relevancy to like people on the street. And that's a big thing we talked about when we were planning all this, is that if we're going to do research, we need to make sure it's done in a way that's guided by community, and that the results of the research are going to be like helpful for community. Like, there's no point of doing research and then it's like nobody is like, okay, like, thanks for the $50, right? It's like, so we want to make sure like the research we're going to do would have impacts and matter for people who use drugs, and I think that it has. So what we did, just for those who don't know, we started a club where we regulated, created a regulated supply of cocaine, heroin, and methamphetamine that we purchased from the dark web, and then created a very, very small research study club where people could sign up. We do this whole sort of big measurement that we based off of VITUS, which is like the substance user survey, and to measure what was happening in their lives before they joined the club. And then every 3 months we'd measure what was happening after they joined the club. And whenever we do these sort of like peer-to-peer services, like they're super, super important. But also evaluation is really important as well, and being like strategic about kind of when we're doing things, because sometimes once you start, like you're like, I really wish I like would have measured what was happening before, because like things have changed so much and so much good has happened, but now you don't have that data. I'm like meandering. So the way that Dolph got our drugs was that we went to the dark web. We purchased the drugs there, had them like mailed, just like super easy. It's ridiculous. Like people who are like, oh, you made drugs more accessible. I'm like, you don't understand. But it takes some like technological skills. So what we tried to do before this was like teach the people who use drugs how to access the dark web, and it was a big disaster. And we couldn't quite figure it out. And we're like, okay, we're going to need to like maybe we can do drug checking for drug dealers, but that's also like a pretty like wild idea because you're creating like a honeypot scenario where it's like you'd like to think people wouldn't get arrested, but we did. Yeah. So we did the market. We were like, okay, someone needs to do this. And there's another topic that I'd like to touch on that I think deserves a lot of conversation as well, is that kind of when we talk about drug user groups and peer-to-peer services, is realizing that sometimes we're asking some of the most marginalized people in our community to do some of the most risky things. And like professionals and people with privilege in the communities need to be able to take some of that risk, and while still maintaining like the integrity of peer-to-peer services. And there's ways to do that, and sometimes that means like doing a lot of thankless work, but it's really important, and that's like part of justice and part of building community and part of building trust. Anyway, so once we got the drugs, we would do quality control, and we do drug checking on that. And that was we couldn't do Dolph without drug checking. So don't get me wrong. Like drug checking is super important. I just think it's best used at a drug seller, drug distributor level. Because it exponentiates, right? Like, drug checking takes like 5-10 minutes per sample. We have people from substance here, like they're swamped, like they're working around the clock. Get your drugs tested is working all the time too. And if you want to do like good quality drug checking, like it's not going to be FTIR. Like you got to use the fancy shit that like tells you the amounts that are in everything. I have a chemistry background. I'm just trying to just gloss over it, but you want to use like mass spec and NMR. Like FTIR is it's just not gonna cut it. It's good for things that are not kind of overdose produce, like a distributor sort of context. But if you're distributing drugs, you want the best quality information you can get, like something like you would expect, like like a food company or a chemical company would be using, I got lost. But you want to, anyways. You want to use mass spec. It's way better, but it takes way longer and it's more expensive. And you can't give that to every single person. It's going to be like buttloads of money. We can't even get FTIRs out. So like good luck getting mass specs everywhere you need them. Then once you got it tested through this like really sophisticated like high quality testing, and this is where the innovation is that we just slap a label on it, right? And here's what the labels look like. This is our first generation labels. We have cocaine, heroin, and methamphetamine, right? And we put a lot of thought into this. We wanted it to be like as low, sort of like non-advertising as possible, even though like people are like, your branding's sick. I'm like, we really tried to keep it simple. And we just did boxes. We tried to make them as tamper-proof as possible. And this is our 5 minutes. Okay, this is our second generation packaging. Right, this is what we upgraded to, because before we were using boxes, we had to fold every single box. And you know who's doing all the folding of boxes? Like this guy. And it took like forever. So we just switched to the bags, which were heat sealed, and they're also more like tamper-proof resistant. So we like that. And the batch number at the top, you see that? That was actually, so when we got our stuff tested at Substance, we would take their code that they gave us, put it on top of there. So anybody who wanted to double check the results could go to Substance's website, which is Drug Checking Services, and put that batch in. And then we have barcodes, which makes it a real sort of product. Yeah. So you know, like why will compassion clubs save lives? Like and what are like some of the really great effects from compassion clubs? And I don't think I need to like really harp on these ideas, but it's a quality control checkpoint, right? Like it doesn't have to be sort of like distributor based. It could be like a cooperative, right? Like a group buying together. Of course, that requires upfront capital, which is difficult. But yeah, it's a quality control checkpoint. So it's like a consumer protection initiative, right? If you have this sort of consumer protection quality control initiative, you can centralize purchasing power, right? Buy more drugs for cheaper. And of course, in the nonprofit initiative, you distribute the drugs for cost, right? There's no bumping up, which is apparently like a really big issue with buyers clubs as well, like in the past. Doing like ARVs and stuff, like profit taking in buyers clubs was a real problem. So it's something to like keep in context. Is that keeping it community based can maybe help address some of those things as well. But anyways, you centralize purchasing power. You can buy more cheaper, which reduces the financial harms of substance use, which are not negligible, right? Then initial point of contact to other services as well, right? It could be a portal as defined by whatever kind of the people who are running it want. It's localized to each community, ideally. Another really big thing, and I think this is like a really big selling point to the sort of like right-wing conservative folks, is like this is like could be a really good way of dismantling like the black illicit market. But and then reparations, justice, like global south, like there's really like kind of like fair trade things that could work into here, and it's like being on top of that I think is really, really important, because if these things were expanded, which is totally possible, in my humble opinion, is that we want to make sure that we're doing it in the best way possible, and like having things like, I mean, like we're in Colombia, right? Like this is one of the places that's experienced like really significant harms from like the criminalization of drugs and the illicit global drug trade. Is being able to replace that by something and not extracting this market out of its roots, right? It's me. I'm doing it. Anyways, we did a lot of research. You can read our research studies online, dolph.ca. We did math. We got significance. We got Mary Claire in the audience. Mary Claire did all the math. I have no time. These are our results. They're available at dolph.ca. I kind of there's like important things here, but people overdose less. People went to hospitals less. People had to commit less crime, interacted with police less. A ton of positive things. Like we just wanted like people to overdose less, but the sleuth of positive effects that we measured was like really, really breathtaking and incredible. Anyways, as I'm sure you all know, like we got arrested and we have to go to court, and if we win, it potentially could change drug laws in Canada, but it's going to cost a lot of money. If you go to dolph.ca, we're doing a fundraiser there. If you have money, feel free to donate, but also don't feel like you need to. Like we'll figure it out. I don't know. Yeah. So we have a legal challenge, and that was part of the strategic planning as well. I'm over time, so I'm just gonna boom. That's our stuff.
Thanks, Jeremy. I wish we could keep going now in that presentation. Well, we only have like 10 minutes for questions. I just wanted to put out, how you started saying, we have to care for our own because nobody's doing that. And so also how we could support besides donating money, any way we could support these litigation processes. I think this is the conference to do it. It goes beyond Canada. It's for the whole world. So we have time for like 2 or 3 questions, maybe. So there's a hand up there. We have another microphone and another one there. So let's start with those 2. Okay. So who has to, go ahead. Maybe, okay, what do you say? I don't know. Because for the translators. 506?
Tracy
Yes,
Gardner
plus
from the
506.
U.S. National Black Harm Reduction Network. So this is the question that I have on my mind all throughout this, because we know
32,
community-led, peer-led, drug user to drug user is what works best. How do you deal with the ingrained antipathy and distrust of drug users, particularly around organizations and money? This is something I have recently confronted or been confronted with, where there is just a lack of trust, even by other drug users, especially by those who are former. So anybody from the panel, but I think that's an ongoing question, is we're comfortable here, but the rest of the world does not trust us.
That's a great question. It's something we've struggled with a lot too. I did a lot of drug user organizing before Dolph, and what we finally came to is just transparency, right? Like making, particularly with finances, is transparency in finances and having those things accessible. And when people ask for receipts, you have those receipts, and making sure that like receipts are tracked is just having that. Like people are going to always say people are stealing money. Like wherever you go, they're gonna be like, who's stealing the money? And it's like, nobody. Here's the receipts. Like look at it. Like it's all there. Like whatever. And making sure and having accountability processes along the way is really important. And making sure that everything's being tracked. Like with the Compassion Club, like the drugs had to be tracked. And we have different people managing the drugs, and accountability, transparency, and tracking, I think is really important, in my humble opinion.
I think we have to acknowledge that it is an issue sometimes. I mean, I've set up and raised funding for a number of networks that have then had the money stolen from them by people who should have known better. Most of the time it's because we tried to make cold appointments at recruitment. We were required to do equal opportunities employment by our donors. And every time we said we were appointing the wrong people, we knew we were, but they did well at interview. So now we don't use cold recruitment at all. We now use recommendation. We have community recommendation, and we're coming up with better systems so that we trust people. Come and work for us, volunteer for us, demonstrate your trust for us, and then over time we then trust you with more and more responsibility. I would also like to say I have exposed huge amounts of corruption in other organisations. I uncovered one NSP program for 6 months. We're going out to a very vulnerable drug scene, selling 20, and then took 20,000 syringes out there and then sold them to local pharmacies. So I've seen corruption at a scale that drug user organisations never get anywhere close to. So yes, we have issues of corruption sometimes, and we know how to manage them, and I think we're getting much better at managing them, and our organisations are super professional now at the global and regional level. But let's not think this is just an issue for drug user organisations. I've seen much bigger corruption in professional organisations.
Yeah. I thought of something too around, working to dismantle stigma. Stigma big time. Because if you think of with alcohol, there are consumption sites all over, probably within, 40 yards, and it's not a big deal. But because of other substances, there's this heavy stigma, heavy criminalization, that's ridiculous. It's killing people, and the criminalization. And I think doing stuff like this, continuing to bring up awareness and have these, and there's gonna be times where there's gonna be these real hard connections in our communities where we're all kind of growing and learning, but to continue to work to, we're in a certain community, and if we're not going to leave the community, we've got to sort of work to educate, each other and work through a lot of hard stuff sometimes, if that makes sense. And I think looking back to how alcohol, prohibition, I think we can learn a lot. Like, how did that happen? There was this really hard prohibition with alcohol, and now it's not. And then a lot of times it's about race. Like, why did people, that got arrested for crack do all this time, and people that got arrested for cocaine in the 80s not do time? Could it be race? Could it be white supremacy? Could it be, colonialism? All these things. And I think the more that we're looking at the structural issues around it and having these hard conversations with our people and using calling in practices, instead of calling people out, it's hard shit. Yeah.
Hi, Lee Hurdle from Chicago and member of Input. Just speaking to what you said, Jeremy, people always denigrate drug suppliers like they're the worst of us. It's important to keep in mind that drug suppliers are drug users, right? And you said using them to drive drug checking. At the peak of my syringe exchange that I ran in Minneapolis, which was unfunded and drug user driven, I was using drug suppliers to distribute naloxone, shit tons of naloxone. I was distributing over 1,500 cc's every 2 months, and I could not have done that without Dan Big and CRA. But we dropped the overdose death rate by 22% in 1 freaking year. But that's how you do it. It was nothing for my posse members to drive around town with 5,000 needles in their trunk and 600 cc's of Narcan. They did it because they loved it, and we made an incredible impact. So don't forget drug suppliers. Ask them to help you out, because nobody wants to lose their clients.
So I would just highlight, if you want to know more about Lee's work one of the EuroInput technical briefings on peer-to-peer naloxone has a case study of Lee's work, well worth looking at. We were also asked, you'll also see the story of my peer-to-peer NSP in Bath, which is almost exclusively supplier run as well, peer-led, peer supplier run. We were asked a question online about how do we make community advisory boards accessible to everybody and not just for the elite. Just to be clear, with the Unitaid project, this is a 10-country community advisory board operating in, I think, 5 languages with simultaneous translation. People, and Input is the secretariat. There are also regional drug user networks involved, bringing in more technical expertise. But there's a huge capacity building program going on with those CAB members over the 3 years. It's really remarkable work from the country to the global. And where we don't have enough community involvement at the country level, we're going in and supporting it. So I think, again, it's about investment, it's about commitment, and it's about not looking at what the barriers are, but understanding the barriers so you can overcome and challenge them. That's the key.
I think, we have a question. I'm just turning everywhere. How is the centralized purchase by non-government organizations are legally challenged? I think they're asking what's your legal problems right now?
Yeah, I mean, we were legally challenged in Canada under the Controlled Drugs and Substances Act, which is the act that prohibits possession of substances for the purposes of trafficking, which we had an exemption to. I mean, my opinion is we did nothing wrong. We've been wrongly charged. We're innocent, but yeah. But that is what they're charging us under. It's under the CDSA, and there's intersections with global drug laws and the kind of prohibitions in that way. Like, that's apparently why they wouldn't want to give us different types of exemptions, or like global drug laws, like the UN. But Colombia's making some work on that. So hopefully one day that won't be a barrier anymore. But yeah, we have national and international laws that are legal challenges.
So we have like 2 minutes. I don't know. We have a question there. Just set up. Go ahead. Yeah.
Was it common for the drugs to contain more than one drug? And then what did you do in that scenario? And I suppose, how did you find the sellers that were selling the pure drugs?
Yeah, so the dark web's a really incredible way of purchasing drugs, right? Because it's like eBay or Amazon when people leave reviews. So there's some like kind of nuances to it, and that like if you leave a bad review, they aren't going to sell to you anymore. But that's our first line, is kind of going through those reviews, looking up forums and seeing who has good stuff. Then you buy a little bit, and you see if it's good. And if it's good, then you buy a larger amount. There were instances where we bought stuff, particularly opiates, where it ended up being fentanyl. And of course, when that happened, it's tossed, right? It's destroyed. And that's part of good about having centralized purchasing power, is that it's not as a big of a hit, right? It's like, okay, whatever, like you eat that cost. But also with the dark web, you have an arbitrator when someone sends you something that you didn't order, where you can get your money back. So we actually, in that situation, we actually got all of our money back. So we didn't have to eat that cost. So that was another like really incredible part of using this sort of system. It's almost like another level of regulation. That's what we thought, introducing like people who were using drugs to be able to buy on the dark web was a good idea. But it's also like kind of the Wild West of getting scammed. We have also been scammed. Like that's part of that.
Okay, so thanks everyone. I think it's already 1. Go to lunch. My pleasure. Thank you guys. Beautiful panel. Thank you. Pleasure. My panel on.
Turn up like